Thank you. On this third meeting, and I hope everybody got the agenda. Should have all gotten that. I just again want to reiterate, please let folks know in your agencies, your stakeholders about the web page, the email, so that if people have comments, that they can make comments. I think we received thus far only one email. And so we just want to make sure that people are aware that, that their voice can be heard and that they can send in written comments by email. So Jim, Dr. McDonald, anything to add?
Yeah, no, thank you, Dr. Cunningham. I'm thrilled to be here with everybody today. I really enjoyed our meeting last week. It was wonderful to have the theme that came across this week. I heard a lot of content, a lot of good ideas, and I think that's just really important. I do appreciate some of the public comment we got as well. And I know my team sent me some background about all the stuff that's going on throughout the state, in particular with law enforcement. And it's interesting. I see a lot of things going on throughout the state that are very discrete. I don't know that we have a comprehensive approach across the state with law enforcement. Maybe we don't need one. Maybe it's different to have one across the state, but it's interesting to see that there's all these different programs that going around the state that involve diversion, which I think is very good to see. So I'm really happy about that as well. I learned about the LEAD program from our team, learned about the ReachNet Medical. Staten Island has their HOPE initiative, which I thought was great. And there's things going around the city with their post-overdose response team, which I thought were great. So, really glad to see that. And I'm looking forward to today's agenda, by the way. It looks good. I know we have Joe Popkin speaking, Dr. Leslie Branch talking, and Charles Williams. I'm looking forward to what that to say. And I, for one, enjoyed all the dialogue last week. I'm looking forward to some dialogue today. It's our third meeting. I only have a couple more left. I think next week is Staten Island, where we're going to be in person. So it'd be nice to keep the dialogue going, see if we get some ideas. And I'm glad we're going to have someone from the Office of Children and Family Services today. I'd be really interested to hear what they have to say. So thanks so much.
Great. And just in terms of the public comment that we did receive, it was from the Monroe County Sheriff's Office, and basically supporting and requesting funding for the county jails, based on our discussion last week, that basically that they're experiencing a lot of individuals with opioid use disorders, and they're providing medication treatment and programming for reentry, and they're constantly trying to find sources for the funding. And so, the email was really just about any help and funding from state or federal government would be greatly appreciated. So I think we can go ahead and just jump into the presentations.
Great. I think I'm first up. This is Joe Popkin from the Division of Criminal Justice Services. I serve as the Executive Deputy Commissioner here, and I'm going to try to share my screen, see if it works. Okay. And then, all right. Can you see my PowerPoint okay? Awesome. So let me go through. So just a brief background on the Division of Criminal Justice Services. So Commissioner Rosanna Rosado and I lead more than 400 employees here in Albany to help keep New Yorkers safe and ensure a justice system that works for all. Really, we are the Swiss Army knife of the criminal justice system, bringing resources, expertise, and information needed to advance a more fair, equitable, and efficient justice system. We've spent the last 2 years kind of touring the state and bringing a holistic approach and strategy to public safety, recognizing that we need communities that are not only just safer, but stronger. And many communities, particularly the ones that are dealing with the opioid overdose epidemic, poverty, crime, other factors have fractured neighborhoods, placing opportunities out of reach. So this is really hard to read, but it just goes you the laundry list of all the things that DCJS does as a multifunction support agency. We train law enforcement, we collect crime data, arrest data, disposition data. We maintain a really robust research apparatus, which I'll talk more about. We maintain all the computerized criminal history records, fingerprint files. We administer more than $600 million in state and federal criminal justice funds, everything from community-based prevention, including support for the Monroe Sheriff, Todd Baxter, all the way through reentry services. And we have nation-leading programs to reduce violent crime that have been necessary over the last few years with the increase in pandemic-era violence. So moving on, in this year's budget, we saw increased funding, the most funding in our 50-year history, thanks to the governor and the state legislator. And that includes areas where we are working to address illegal narcotics and substance use disorders. So we have $7 million dedicated to prosecutors to disrupt the flow of illegal fentanyl supply throughout the communities. We have $2 million in additional support for crime analysts, which I'll talk more about. We have really record funding for our alternatives to incarceration programs and pretrial services, and $11.5 million for reentry services. And just for some context, these are funding streams that hadn't been increased in over a decade. So really, I think it's right-sizing the investments in New York's criminal justice system to stop the revolving door that we've seen. We know that the justice-involved population and people with substance use disorders, there's a large overlap. We see, between 50 to 75% of people in the justice system having past or current substance use disorder or mental health disorder. And so the money that we're putting towards alternatives to incarceration, pretrial services, and reentry are really meant to divert people away from formal engagement in the justice system and toward the services and supports that they need. So shifting gears to talk a little bit about enforcement strategy. So New York, since 2008, has had kind of a first-of-its-kind network of regional crime analysis centers, so also known as CACs. And the CACs were really started with changing the couch cushions. It grew over the last 10 years to be about $8.1 million. And under the governor's leadership is now $17 million. And what CACs do is there's 11 of them now, so this map continues to be out of date as soon as I develop a new PowerPoint. But we have 11 CACs, including in New York City this year. And it collects and shares and aggregates information from over 350 law enforcement agencies in I think we're in over 45 counties now. And it becomes the way that investigations, leads, other things start. And also when we see, narcotics or drug supply, particularly over the northern border, we can connect those linkages and cases to more effectively enhance not only arrests, but prosecution of those cases. And so last year they did, I believe, 70,000 requests for service from law enforcement, everything from can you help us with a license plate reader, all the way through hotspot analysis and some of the products we'll talk about on overdoses in just a second. So within the CAC network, as we mentioned earlier, the governor provided an additional $2 million. And so we're using that to continue our partnership with HIDTA, the High Intensity Drug Trafficking Areas Program, which is a federal program. And we're embedding analysts focused solely on narcotics throughout all of the 11 centers that we have, which cover the state. We make sure that all the centers use ODMAP, which is a dashboard to track overdoses, focusing on trends, movements, and hot areas. We generate on a monthly basis, or sometimes more frequently, from all the CACs, a overdose kind of map that's a more detailed look beyond ODMAP about what's happening within each region, and we make it available to all the participating law enforcement agencies. So everyone has kind of a shared picture of, here's the calls for service, here's the administrations of Narcan, here's where we, had reports of overdoses, so that we can better gear not only our response efforts, but our prevention efforts. And as I mentioned, we are expanding dedicated crime analysts, drug intelligence officers, and National Guard staff to each of the 11 centers. Several of the crime analysis centers also have really robust partnerships with local law enforcement and local health. So they will track where naloxone has successfully reversed an overdose, and then help trigger the a follow-up outreach and services that are necessary for individuals who have been saved by naloxone, the Narcan administration. So that's an area where we want to grow and see if we can model that in other centers throughout the state. So on law enforcement training efforts, Going back almost a decade, 2014, DCGS, in collaboration with DOH, began delivering the intranasal naloxone training to law enforcement. Since then, we've had more than 11,000 officers representing over 600 agencies completing the training and reporting that to DCGS, and they have delivered naloxone more than 14,000 times. So we think that's a success, but we also know that as we continue to fight the opioid epidemic, we have more work to do. So building upon this 1-hour training, which has been updated throughout the years, we've done a few other things through our Office of Public Safety here at DCJS. So the first thing we did after that training is we created a model policy that is shared with all law enforcement agencies as a best practice, and that model policy is shared widely, but also comes from our Municipal Police Training Council. So the Municipal Police Training Council has representatives from the state police, from the Sheriff's Association, the Chiefs Association, and for each of the model policies, we also work with the subject matter experts. So subject matter experts rather. So we worked with DOH and OASAS on this policy. As I mentioned, we continue to update the law enforcement training offerings. So in 2018, before the pandemic, we worked with Albany Med and DOH on a refresher course. That's about 15 minutes and is accessible online. It incorporates some new information about the new naloxone kits that are offered by the Overdose Prevention Program, which don't require an assembly anymore, as well as an overview of changes to the Good Samaritan Law, naloxone community access laws, and syringe access. Since this was debuted in 2018, more than 2,000 officers have taken the refresher course from over 280 agencies. So DCJS and the Municipal Police Training Council set forth the minimum standards for all police officers. It's called the Basic Course for Police Officers. It's 700 hours. And that's been updated to make sure that we provide training on the Good Samaritan Law and public health law, particularly as it relates to syringe access and naloxone. We, in 2021, updated it again to make sure that we are teaching officers that it's prohibited to use the presence of an opioid antagonist as a probable cause for an arrest, as well as updates to decriminalize the possession of a hypodermic needle or instrument. We also updated our in-service naloxone trainings. Last year and this year, we issued memos out to all law enforcement agencies, letting them know that we had updated in-service training materials. We added new sections on fentanyl and xylazine, as well as information on NCAP, and the statewide reporting efforts for overdoses, which is where we got the data from that I referenced earlier about law enforcement administrations of naloxone. In addition to the work we do with police and peace officers, we also oversee probation departments, and we make sure that there's naloxone training provided to probation officers in the same way we do police officers. We also provide materials to each of the county probation departments so they can train their officers. And we've done about, I think, annual webinars for probation departments as well as community correction programs like our alternatives to incarceration and reentry programs on general trends that we're seeing in substance use disorders and justice-involved people. I think we just had one last week, I believe, with OASAS. And we've added elements to that training as we've gone because I think there has been a lot of law enforcement, misperception of treatments that are evidence-based, such as medication-assisted treatment. And so we view our role at DCJS as bringing that information, bringing the subject matter expertise, and trying to demystify perceptions of those medication treatments that save lives. We've also been working with DOH on the Medicaid 1115 waiver to expand Medicaid coverage to justice-involved people, particularly upon release from incarceration. This has long been a project of mine, going back to when I was in the governor's office in 2016 and 17, and started working on the original waiver amendment. And it's great to see that there's some movement now from the federal government in granting California's 90 days before release, and I hope New York follows suit, because I think this is really one of those key linkages where we know that the risk of overdose is 11 to 12 times greater for people who are returning from incarceration than it is for the average public. And so it would be great to see some more continuity of care. And the state has gone and done a lot of administrative actions in this area through the state's reentry council to unsuspend Medicaid so that we can get some providers lined up, but there's more work to do there, particularly when it comes to billing and coverage. So that's really, I think, an area where we see from the field a lot of growth and where we could do a lot of good. In addition, we know the state's, our Office of Justice Research Performance partners with and works with the statewide epidemiological outcomes work group. That work group focuses on using data and analysis to help drive prevention and treatment efforts for substance use and mental health disorders. In addition, that area within DCJS also administers our criminal justice knowledge bank. So we summarize promising local practices like Albany's Law Enforcement Assisted Diversion Program, LEAD, which you heard about, but also Richmond's HOPE program, which the commissioner mentioned, and Albany County's SHARP program. So we develop these profiles so that they can be shared throughout the communities of practitioners in New York State. So just to circle back on, there was previously a reentry council. It's now been kind of rebranded and reinvigorated this year as the Council on Community Justice with the Lieutenant Governor and DCJS Commissioner Rosado. We're really looking at ways to improve the effectiveness and fairness of the state's criminal justice system. And as we've had our kickoff meeting and similar to this effort, substance use and mental health disorders have become a key focus when we look at all the areas of the criminal justice system, from prevention to diversion to corrections and reentry. And so I hope to use some of the learnings of this task force, bring it to the council, and hope to have a kind of a unified strategy, to your point, Commissioner, around how we best prevent system involvement for people who have substance use disorders and ensure they receive the treatment that they deserve. So I know that was a lot of information, but I'll pause there. And I don't know if we hold questions to the end, but I'm happy to answer any questions you might have.
Thank you so much. I think that was great. I think maybe we should hold questions to the end, if everybody's okay with that, just so that gives us a nice chunk of time for a discussion. Great.
So based on the agenda, I think I'm following my colleague Josie. So I do not have a presentation. I bring you greetings from the New York State Department, where our commissioner is Reverend Viviana DeCohen.
Wait, Dr. Branch,
yes?
It's really hard to hear you. I don't know if others can hear you.
Let me turn up the volume. Is that
Much
better?
Yes.
Okay.
Great.
Well, there we go. All right. So take two. Action. All right. So I am happy to give a presentation today. I am Dr. Leslie Branch. I am Special Assistant for Community Engagement at New York State Department for Veteran Services, where our commissioner is the Reverend Viviana DeCohen. And to sum up our agency's mission in 3 words, find and serve. And when asking veterans, oftentimes, if they need something, their response is usually no. But what veterans actually is entitled to everything for their services that they have rendered to this country. And just for context, I'm 4 months into this role with DVS, and so I'm probably one of the infants, if you will, in state government. And in terms of context for the opioid use and situation among veterans, I'm told it really came to a boiling point in 2014, where national attention was placed on a VA medical center in Tomah, Wisconsin. Not going into all of the details, but veterans who have chronic pain based on injuries that they sustained during service were prescribed opioids. And then when that sort of boiled over, the pendulum swung in the other direction, where veterans were expected to just go cold turkey and come off of the opioids. And cold turkey is probably not the best approach. I'm not a doctor in that sense, And so we saw a correlation with an increase in suicides among veterans. And so some of the things that uh, the New York State Department for Veteran Services are doing with regard to the um, the addiction and the suicide uh, is we are developing, launching, and sustaining a first in the nation online interactive tool for families of service members, for veterans who are worried about their loved ones and are seeking resources about how to engage them in productive conversations about what is a very difficult and uh, in some instances a taboo topic. And so this site that the team has developed continues to maintain, and it's called Worried About a Veteran.org. And the website discusses a number of crucial aspects in the realm of lethal means safety, including information concerning potentially lethal medications and the like. Also about the safe storage and other recommendations around firearms. The website is informational, it is interactive, and the site provides guidance based on lived experiences in areas from starting the conversation with a loved one to taking steps in the home to substantially reduce the risk of suicide and self-harm. Another initiative that DVS is working on has been collaborating with the Columbia Lighthouse Project to provide free, widespread training and implementation and the use of Columbia Suicide Severity Rating Scale. Um, and this screening tool, which has received acclaim nationally, I'm told, and internationally for its accuracy um, in identifying individuals at heightened risk of suicide and self-harm, can be utilized by any person who's willing and able to engage someone in a short yet meaningful conversation. And so, with suicide deaths by drug overdose remaining a significant proven risk among veterans, the use of this particular screening tool by our veterans benefit advisors and our veteran service officers, as well as others working in the veteran services arena, can prevent overdoses and save lives. A third um, uh, initiative or partnership that DVS is engaged in is maintaining a close partnership with OSAS, OASAS, and it's particularly, I'm told, with the Veterans Liaison, Christopher Moses, and before him, the Governor's Challenge Team member, Paul Noonan, who I'm told is retired. And we make referrals to our partner when we work with veterans who are facing opioid addiction battles. DVS has received trainings on a regular basis from our partners, both in person and online. And DVS likewise has provided trainings about other services for various groups of our partner staff. Additionally, um, information is displayed on our kiosks that are around the state of New York. We also have kiosks in the how do you call it, the convention center in Albany, where veterans can learn about a variety of programs that run the gamut from education benefits, health benefits, and topics around addiction and suicide. Let's see. And then finally, we work with an organization. Let's see. Blah, blah, blah. We have the outdoor recreational therapy that's focused on veterans and military families, and that effort is designed to provide veterans and their families with access to guided programs and services on New York's public lands. that can improve the health of their overall lifestyle, because green space is so important to mental and physical well-being. Uh, and I'm going to cap it right there. And thank you for the opportunity to share some of the things that PBS is doing.
Thank you, Dr. Branch. Great, so we'll move on to Charles Williams.
Thanks, and good morning. I'm Charlie Williams, the Assistant Director for Healthy Aging and Longevity at the State Office for Aging. Thanks for the opportunity to give some background on our state office and the efforts related to our work at hand. Our mission is to help older adults in New York be as independent as possible for as long as possible in their homes and communities of choice. Our home and community-based programs provide older adults access to a coordinated package of supportive services designed to support and supplement informal care. Our overall goal is to improve access to and the availability of appropriate and cost-effective non-medical supports to maximize older adults' ability to age in their community, avoid higher levels of care, and enrollment in publicly financed care and support services. We are aided in achieving this through our network of 59 area agencies on aging. They are the ones that are providing that network, or that suite of 19 core services in coordination with local partners. Some of our services include home delivered and congregate meals, nutrition counseling, health promotion and wellness services, including access to evidence-based interventions, personal care, case management and social adult day, and we also house the state's long-term care ombudsman program. What we do know is that older adults in New York are a tremendous asset to families and their communities, as well as being a vital part of New York's economy. We're home to the fourth largest population of individuals over the age of 65, and we view this as a tremendous opportunity. Older adults are the #1 givers to philanthropy and charity, #1 entrepreneur group with over 60% of new businesses begun by those over 60 in New York in the last several years, and represent the largest volunteer cohort, giving their time to thousands of local nonprofits, and are a huge part of New York's tourism industry. What we also know is that adverse drug events cause approximately 1.3 million emergency department visits and 350,000 hospitalizations for further treatment each year nationally. Older adults are at increased risk for these adverse drug events. This is due to a combination of metabolic factors and the increased potential for drug-to-drug interactions, as older adults tend to have more prescription medications and are also therefore more likely to have leftover or expired medications. Add to that more than 30,000 unintentional drug overdoses among older adults and 65 and older between 1999 and 2020 nationally, which is a 700% relative increase. These are often a result of prescription pain medication for chronic pain, a result of an injury or fall. And as with the increased use of opioids and derivatives and pain management, older adults have also experienced an increased use of psychostimulants, and which has also contributed to this recent rise in overdose and death statistics. As a result, like I said, there's 2 pathways for older adults that receive our services. 2 substance use disorders, those with a history of substance use disorder already from a younger age, whether continuous or interrupted. And the second encompasses older adults newly diagnosed and whose substance use is often driven by one or a combination of the foregoing factors mentioned in late traumatic events and exposure to prescription psychoactive drugs. Our aging network providers have been working with partners at state and local levels to utilize our reach to enable collaborations addressing the public health emergency. Since our case managers are already in the homes of older adults, they have a deep familiarity with their individual needs and are helping to educate them on a range of safety issues to keep them aging in place, including medication reviews. The average person on our caseload has 4 or more chronic conditions, and these conditions can require upwards of a dozen prescription medications with overlapping refill and expiration timelines, which increases the risk of adverse drug events and interactions. we try to offer effective tools to help older adults and their families reduce preventable hospital admissions or readmissions, and in the case of medications, limit negative interactions and possible errors. We have also figured the best way to deal with this complexity is to partner with the experts and pursue simple solutions that can be understood and incorporated by older adults living at home or alone. Our office and OASAS, along with our network of aging services partners, have collaborated on several programs that address issues related to substance use disorder and these adverse medication interactions. One is a partnership that brings safe disposal for prescription drugs to older adults. We've shipped over 100,000 doTERRA drug deactivation and disposal pouches to aging service providers for distribution and delivery to older adults. They're designed to destroy the unwanted or expired medication safely and permanently making them unavailable for misuse. Once activated, they can just be thrown out in the trash and are easy to open, use, and get rid of for older adults. In addition, in the past year, we've launched a couple of programs to expand older adults' access to services and supports related to substance abuse or addiction. This has included ways to incorporate the screening, brief intervention, and referral to treatment, SBIRT, evidence-based approach into our case management and screening tools. This screens individuals who are seeking service or assistance through their local office for aging to identify use of alcohol and other substances at risky levels. This approach has been shown to be valid and reliable in identifying and improving outcomes for people who use substances. And we're very happy to have included it into our normal course of action and our screening efforts. Another effort combining our aging network and those programs offered through OASAS is the Wellness Initiative for Seniors Education. The WISE program is for older adults focusing on healthy aging and making healthy lifestyle choices. It includes education topics for regarding substance misuse, medication management, stress management, and depression. In the past year, more than $1.3 million in funding has gone to support the expansion of addiction prevention efforts for older adults. 8 OASAS prevention providers are receiving funding through this initiative, which involves both WISE and SBIRT. And if you just bear with me for a couple more minutes, we have 2 more efforts at the state office through the Department of Health and our statewide foundations addressing negative medication interactions and promoting preventive care and support, which are the age-friendly health systems and age-friendly planning efforts. The age-friendly health systems effort is a technical assistance program for health systems, long-term service providers, and our area agencies on aging to pursue certification from the Institute of Home Healthcare Improvement as an age-friendly health system by implementing the John A. Hartford Foundation developed 4 M's model of care, where the M's stand for mentation, such as early detection of cognitive decline, reducing the incidence of delirium, and promoting, neurocognitive experiences in older adults. Medications, dealing with medication management and avoiding unnecessary medications, negative interactions, and or overprescribing issues. Mobility, which promotes not only the ability to get around for older adults, but to be engaged in their community of choice. And what matters, which is pursuing a course of treatment based on the goals and preferences of older adults and incorporating person-centered models of care into treatment. Participating systems are trained on the use of these 4 evidence-based elements to organize care for older adults, and then when implemented together have resulted in significant improvements in care and service delivery. Age-friendly facilities see improved patient experience scores, as well as quality outcomes for readmissions, emergency department utilization, and length of stay. The other benefit of this approach and system is it encourages collaboration among subspecialty public health and aging services network providers to ensure a holistic wraparound provision of care and opportunities to improve conditions for healthy aging. The age-friendly planning side of things provides similar technical assistance and networking, but to our local government partners. This effort has tied together planning and infrastructure, public health, and local government representatives into teams to develop networks and collaborations that can better address social determinants, improve the aging experience across the lifespan. Communities that have participated have undertaken steps to develop cross-government teams, working collaboratively to break down silos and addressing public health issues in their communities, including certification with AARP as a member of their network of age-friendly states and communities, and adoption of local resolutions, making permanent these collaborative approaches to the aging experience. With that, happy to answer any questions you might have. Look forward to working with you all and how we might utilize our aging services network, as well as our office's relations to facilitate access to substance use disorder services and reduce the incidence of overdose and adverse drug interactions. Thanks.
Great. Thank you so much, Charlie, for that. I think, so our last presentation, I think, is going to be from OCFS. I know it was tentatively on the agenda, so. Sorry, go ahead.
Hear me? Strange, but this is Madeline from OCFS.
I can barely hear you. I'm not sure if others also.
Is this any better?
That's a little better.
So good morning, everyone. I'm Madeline Hare. I'm from the Office of Children and Family Services, and I apologize. I've been out sick all week, so I only have a couple talking points, not a full-blown presentation. But happy to share, some of what OCFS is doing in the space of overdose prevention. So OCFS, the Office of Children and Family Services, is a large O agency that has the regulatory and oversight responsibility over child welfare. So everything from investigations of child abuse, neglect, maltreatment through foster care placement when that's appropriate. We also do direct operations of the deepest end of the juvenile justice system. So we have facilities where young people who have been found guilty of certain crimes are offered services and supports. And we also support a wide variety of community-based services for young people. So overdose prevention, I think, is probably newer to our agency than some others who have been deep in this work for a long time. We have noticed, unfortunately, an increase in fatalities from overdose in the last year or so, especially in the runaway and homeless youth body of work, which is in my Bureau of Youth Development and Partnerships for Success. The overdoses that we have seen recently are almost all connected to fentanyl. We have met with OASAS leadership, I believe it was last summer, to really dig into the intersections of our work, and that convening led to the formation of a number of subcommittees that are continuing to meet to this day. They each have a different focus on things like education, prevention, pretty wide variety of topics about substance misuse generally, not limited just to overdose prevention. In DJ Joy, which is our division focused that directly operates the deepest end of our juvenile justice system, they engage in regular work providing substance misuse treatment to young people when they're placed with us. So if that is an issue for a young person, they get clinical supports, and they also help coordinate supports when they leave facility and return to their community of origin. DJ Joy is also working with OASAS to update standards for what treatment should look like, and they are also doing some training for our medical and psych staff around opioid use disorder, including rescue medications like Narcan. In child welfare, CWCS is our other major program division. They have the oversight of child welfare voluntary agencies and districts, departments of social services. They are offering quite a few trainings to professionals around substance misuse, including overdose prevention. And in WIDAPS, my division, we primarily focus on young people ages 14 to 21. So that includes older youth in foster care. It includes runaway and homeless youth and it includes youth who are detained pre-adjudication. We operate our supports and services from a harm reduction perspective and positive youth development. That has always been our approach. And we're just really ramping up the harm reduction language, especially in response to the fatalities. So what that looks like is we've been engaged with OASAS's harm reduction team over the last year or so. We've made trainings available to our providers. We're hosting a summit in November to dig into harm reduction in practice more concretely. And what we're doing at that summit is focusing on the program leadership. What we found is that when we do trainings for line staff, they may or may not buy into what we're saying, but either way, when they go back to their program and try and implement harm reduction, they're met with resistance from leadership, who tends to be a little bit more risk averse because we're talking about young people. So what we're learning is that if we really want harm reduction to be embedded in a meaningful way, we have to start with leadership buy-in. So that's happening in November. We're also pushing out policies about opioid antagonists, first in our detention facilities and then in runaway and homeless youth programs, to make sure that staff and young people have access to Narcan and can use it as they need to. We're also interested in bringing that Narcan training to our own staff in case we need it in the office or in the field. Our other major division is childcare, which traditionally has not really had space here, but we all know there was a tragedy last week in the Bronx, so that could potentially change. So those are some of the highlights of what we've been doing, and happy to have discussion about that.
Great, thank you, Madeline. So I think definitely time, we have plenty of time to have a nice, robust discussion. And Dr. McDonald, I'm not sure if you want to sort of lead us through this, because I know you had, posted some of these potential questions for discussion.
I put some questions out there just so we could have something to dialogue about when I saw the first agenda, because there weren't as many speakers when I first saw it. And I thought it might get some coalescing questions, but I think what might be better right now is maybe ask some questions of the speakers first to get everybody participating there, if that's agreeable to you. And then we can move to these questions at a time. I mean, one of the things, I'm very cognizant of is like, this is a really unique opportunity to get all the agencies together and have all this conversation. It's great. I don't want to lose the advantage of this. So I do want to make sure we get as much input as possible, but I had some questions for some of the speakers. If we can just dialogue about those first, we don't have to go in any order, but if that's agreeable to you, that's what I'd like to do.
Sounds great.
Since I'm having the microphone open, I was just thinking if I can go back to Joe Popkin first, I really appreciate everything you were sharing there. And one of the things that you were touching on is it's interesting how much pre-arrest work is going on in different parts of the state, Joe. But I don't know that we have a statewide pre-arrest strategy or pre-arrest diversion strategy. And is that something we should be looking at to do? I'd love to dialogue a little about what that could look like statewide and what would be if it's a good idea, what's holding it up? I'm guessing I know the answer to that, but I'm just curious what you think.
Yeah. So I think there's two things. One is always comes back to, funding and resources, but also there are so many different models of both diversion, but also like co-responder models for mental health and other crisis kind of interventions. So taking them one at a time, on the response that law enforcement has to calls for distress, whether that's somebody who's overdosing or an emotionally disturbed person or somebody who's in the throes of a mental health crisis, I think that there are good national models, and there's some places like Buffalo that have done a great job in creating a co-responder model using community-based mental health providers and substance use treatment providers. But that isn't always replicable in all areas of the state, given the fact that they might not have the same service saturation, or that they're all pulling from the same kind of pool of clinicians, so to speak. So we've had some conversations with OASAS about this, but and OMH, but I do think as we scale up our services and the integration of mental health and substance abuse, that we should think about the connections we can create between 988 and others with law enforcement, who are often called kind of in the first instance. So that's kind of one thing. And then the second thing, when it comes to diversion, there's not necessarily always a one-size-fits-all model. So here in Albany, we worked going back to 2014, 2015. I was on the governor's team. It was called Community Opportunity Reinvestment, and we worked in Albany and Newburgh. And in Albany, we worked to get the law enforcement assisted diversion program off the ground. But it took a unique moment in time for all of the partners around the table to say, okay, yes, arrest is the point that we want to make the diversion, not during prosecution or not during, a court intervention. And so I think it's about providing the menu of options to each of the different counties around what diversion might work for them and what it might look like. And I think it comes down to cost, coordination, and the kind of political will to set that table, to get everybody around the table. One of the things that I thought was really inventive about what happened in Albany is that they used a variety of different funding sources to support their diversion. So they, partnered with Albany Med, used some of Albany Med's funding. They did robust kind of Medicaid enrollment to kind of cover some of the costs. And then the city covered the costs of the social worker to be able to do the diversion. So I think as you look at scaling these, DCGS is well positioned to work with DOH and OASAS and OMH on kind of a template of diversion programs, but it's going to come down to what is right for each of the communities and how do we make a sustainable cost model for them, given the fact that our funding systems don't always kind of braid together as nicely as I think we'd all want them to. But that's a really long, convoluted answer. I hope I got to something there.
No, I appreciate that, Joe, and I don't want to monopolize it, but just to follow up like that, do we have, and I'm never trying to play Stump the Star here, so if you don't know the answer, that's totally fine, but do you know how we're evaluating the law enforcement assisted diversion program, and has it been successful? I mean, I just share a little bias. I'm sort of someone who's had experience with programs like this.
Yeah, so two things. One, for LEAD specifically, I believe they partnered with some academic institutions. We might have actually funded some of it to look at outcomes. Not only do they not get rearrested or reconvicted, but also do they have better, health outcomes, labor outcomes. And I think that the first look at the evaluation was more of a process evaluation to make sure that it was implemented with fidelity. I think in terms of an outcome evaluation, they've seen some success, but they've also had, at the time, I think they only had a few dozen participants to evaluate. That's grown, obviously, now. So I'd have to go back and look at the evidence. I would say for our other host of alternative to incarceration programs, which runs the gamut from everything from jail-based programming to cognitive behavioral interventions to, trying to think of the delivery of interactive journaling, all of those. We have done about a decade worth of work with Pew and MacArthur Trust Foundation on evaluating that. And we know that each dollar we put there returns about $4 in avoided system costs. So we know that those people are not, once they receive the treatment and services, they're less likely to end up with system involvement, and they have better connections to education and employment. And that was really the best case that I've seen in government of kind of evidence-based and evidence-informed service delivery, at least within the criminal justice sector. I know health, it's more common to do the evaluations. So.
I also just want to jump in around the crisis points that you had made earlier too, just to point out that, there is the new task force on Daniel's Law, and Commissioner Rosado from DCJS, myself, and Commissioner Sullivan are all part of that, along with other stakeholders. And so that is like another committee, advisory committee, that's focusing specifically on that piece. And I think there'll be more, right, to come. The first meeting was just a few weeks ago, and those meetings are ongoing. So just to sort of point that out, that work and the collaboration is definitely happening as well in that other task force. Yes. Yep. No, I think it's great that we have this kind of assembly of agencies that are working so closely together and coordinate efforts. And in my mind, the criminal justice system
represents the failure of all the other systems, right? The education system failed, the health system failed, the social services system failed, you know, in order for you to get to a point where then your justice system involved. And so the more we can do system integration at our levels, at the management level, and really at the provider network level, the better off we are. I think one of the things that the commissioner and I have done over the last year is we did 7 cities last year, 15 cities this year, and we meet with all of our funded programs on the ground. We do a morning session with law enforcement, we do an afternoon session with community-based organizations, and it's surprising sometimes that this is the first time they've been brought to the room together. You know, they all receive state dollars, they all, you know, kind of are serving the same clients, but in many areas of the state, it's the first time they're being, you know, engaged in this way. And I think the things that we hear from that kind of perspective in the field or on the ground, so to speak, is, you know, their challenges with justice-involved people run the gamut. It is, yes, it comes down to case coordination, but it is also incumbent that we deal with the substance use disorders and we deal with the mental health disorders in the first instance. I think one of the things that government does really well is set up programs and evaluate them, but we don't always look at the actual recipient or the family as the unit of care. And I think the more we as state agencies can kind of get to the ground level, the better off we are and the better our insights are. But that's me off my soapbox for the day.
And Joe, if I could just add a thought to that real quick. It's interesting, you said all these other systems has failed, and I think I know what you mean by that, but I think there's a common misperception. In the United States, there really isn't a healthcare system. We have a healthcare marketplace in the United States, and there are health systems in the United States. The Veterans Administration has a healthcare system. Department of Defense has a military health system. The Indian Health Service has a health system, but you really don't see a health system in states. We have a marketplace, and I think just to want to be clear, like, there isn't a comprehensive place where people can go and have a comprehensive approach to health. And part of why I say that is, as we look at places where we can share ideas with each other, one of the things that we could think about is, like, would this epidemic be better if we actually had a health system? And I'm not trying to criticize your word choice, my friend, but
Yeah.
I don't think it's fair to say the health system failed. I mean, the bottom line is we just don't have a health system. It's a marketplace, and if you can't enter it, and it's not designed to, we're trying to make it as accessible as possible, but it's got challenges. It's not universal. It is what it is, but it's a barrier that we need to address and be honest about, I think.
Yeah. Yeah, and I use the word system to be in the most broad sense of the world, avoiding government or agency, because you're right, it is a marketplace, and it's more, in my mind, a patchwork of social supports that have not meaningfully captured and served the people who are on a path toward antisocial or delinquent behaviors or criminal behaviors that we've talked about. And so, it's the person who shows up in the emergency department because they don't have preventative care, like they're not being served by the marketplace. And so what ends up happening oftentimes, like we see, is this revolving door of someone getting further and further system involved, so to speak, again, broad terms. And that path that we see, particularly for young people or people who have substance use disorders or mental health disorders, leads to justice involvement. And the last thing I'll say is just, I think this is a manifestation of policies, but also practices that date back 50 years, right? So the deinstitutionalization of mental health services in the 70s, leading to this kind of growth of the criminal justice system as the apparatus to deal with people who are in the throes of mental health disorder or significant substance use disorders that are debilitating or are detrimental to their conduct in society. And so that's why, the Cook County Jail in Illinois still remains the largest provider of mental health services in the country, because of the fact that we've seen this kind of manifestation of the justice system as something else, as the delivery system for other, health or mental health or substance use services. And I think we can have the conversation about whether that's appropriate or not. I think recent legislation has kind of right-sized and said, we really need to do a better job of investing in, to use your word, the marketplace, so that we have, going back to the Affordable Care Act, we have more coverage, but also the preventive supports that our colleagues at the OCFS talked about, and the investments that the governor's made, the $1 billion in mental health. So it's about right-sizing what we saw as a drift in the system over the last 50 years, so that the justice system is really reserved for people who have committed crimes and are there for rehabilitation purposes, not because they have a substance use disorder or a mental health affliction.
Great, thank you. And just for others, maybe if people can raise their hands, if they have comments or questions for any of the people who provided presentations today. And let me just also ask a follow-up, Joe. So it's interesting what you said about the sort of getting together with community-based organizations and in the areas that you have done your visits. I wonder if there's a role to get together with also like so for us, we work with the directors of community service for each county, right, where they're oversee mental health and substance use services, and then I know that each county has the commissioner of health, for example. I'm just wondering if it would be helpful for like all of those, for everybody to get in the same room, right? Because I think we are having some of these discussions about these like diversion programs, for example, with our directors of community service, but like the other half of that equation is not in the room, right? It's just, and then I'm sure you're having it, but with your half, and then the other half of the equation is not in the room. And so I'm just, I'm thinking that maybe it would be helpful to kind of bring, right, those sort of different pieces together at the county level to, again, hear about the kind of promising practices and how that could be potentially expanded in other counties.
I think it's a great idea. I mean, one of the things that worked really well is 2014, 2015, DCJS and OMH received a grant to do Mental Health as Justice Collaborative. And so we worked in, I think, 11 counties. It might have scaled up to 17 counties where we did just that. We went to the county, we got both sides of the equation there, the social side, the health side, and the criminal justice side, and we did sequential intercept mapping, right? How are the clients who are here now, how did they get here? And what were the points of intervention along the way that we could have meaningfully, provided services? And I think that model worked really well, but like a lot of the federal grants that I know folks on the call have experience with, it's time limited. It works for 2 or 3 years and then it goes away. And so I think some great work came from that, but replicating that, institutionalizing it, and maybe looking at the data that we collect both on the justice side and the health side, we could pick, a few counties to pilot this type of an effort where we're bringing state government into the community in a more intentional way. And I think we should also think about some of the city services and the community-based organizations that are, in that space, because there is sometimes a loss of translation across the different defines of government from fed to state to county to city. And so making sure they're all aligned is in and of itself the task. So I think it's a great suggestion. Thank you, Commissioner.
Thank you. Other comments, questions? Pedro.
Thank you. I find this conversation fascinating. And I agree wholeheartedly with the Commissioner that we have a marketplace for healthcare as opposed to health-oriented services. And that gets me to Madeline's presentation. I found it, I wholly agree with her presentation regarding the triangle of homelessness, mental health, and substance use among young people. And in our research, what we often find is the access to treatment is not readily available. It's hard. They might have insurance, but it's their parents' insurance, so they might not be willing to disclose. Oftentimes, substance use results in homelessness, so they attend youth services. So I wonder if within that framework of harm reduction, beyond Narcan or naloxone distribution, is there any way that we could create within these youth services low threshold access to MAT? say buprenorphine, and ideally addressing the comorbidity of mental health. I think that's a bit of a pipe dream, but certainly it goes to this fascinating policy conversation I just heard. Thank you.
You're absolutely right. One of the many barriers that our young people in runaway and homeless youth programs face is access to care once they decide they're ready to receive it. There was a legislative change that happened earlier this year that allows young people in runaway and homeless youth services to consent to their own health care in the same way an adult would, which includes mental health, substance use treatment, etc. But if they are on their parents' health insurance, their parents' health insurance will still be notified. Their parents will still get the explanation of benefits and so forth, which remains a barrier. We do have some programs that have, I think it's CASAC, and also mental health clinicians embedded, but most of them do not. Most of them rely on partnerships in the community and referrals to help young people meet those needs. And as I'm sure folks are aware, wait lists are incredibly long. And so our young people sit there and they struggle while they wait. And we've been working closely with OMH and with OASAS to try and bridge some of those gaps. And there are some new ideas coming out that we're really grateful for, but they're still kind of in the infancy stages. So I would also just flag for folks that our runaway and homeless youth program budget for the entire state for residential ops is $7 million. So if you work with budgets, you know that does not get you hardly anything. And that is another barrier.
Thank you.
And I just want to add to that, we do, I'm just not sure if people are aware, but OASAS does have residential treatment services specifically for youth. That is one part of our system. It's small in terms of the number of, residential beds, but that does exist. That is really specifically for, it's sort of young adults and youth. For that specific age group. So we have, we certainly recognize that there are, unique needs for sort of young adults and adolescents as compared to older adults. And so some of the ways in which we've been doing that is this like very specific residential treatment program for youth. And then we also have been working to do sort of best practices with the existing programs that really exemplify how services should be provided for young adults. And so we have what we call a designation. And so some of our programs are sort of designated as doing an excellent job for young adults and young people. And so that's kind of the vision that we have going forward, so that they're clearly identified as programs that are sort of young adult and youth friendly and have best practices, and then we're really thinking about how can we scale that up further, and so that's kind of it's not exclusive to young people, but it's sort of a like best practices, and then thinking about how we can expand that, and then making sure that they're designated so that people in the community then know that that's a place of excellence for young people. Other questions, comments?
So I'll jump in again real quick. So Madeline, if I could just follow up with you a little bit about some of the information you shared. I know you covered a lot of great information really effectively, and my goodness, for someone who was sick for a week, you looked like you didn't miss a beat. So appreciate that. But I noticed one of the things you shared with us was that you saw an increase in overdoses in people who were considered runaways, and it was attributed to fentanyl. And I'm just, wondering aloud, are we seeing more people in that population? Are there more runaways? And were these fatal overdoses or non-fatal overdoses or both? And again, never trying to play stump the stars. So if you don't know, it's fine, but I'm just curious if you had any wisdom to share there.
Yeah, our numbers of the runaway and homeless youth population are relatively stable, but they're one of the many populations that's basically impossible to count. So we're really measuring based on who's accessed our services, which is pretty stable. And the increase in overdoses is a mix of fatal and non-fatal. When I started this work, fatalities in our program was unheard of. It just never happened, and we had, I think, 9 in the last 2 years. It's a very alarming increase in fatalities that has a strong correlation with fentanyl.
I'm just thinking out loud, but I think one of the things that's interesting to me is just like as the supply of more potent product is increasing over the last decade, it just seems like this is something you're going to see as more and more populations that weren't affected now being affected. Because, one of the things I just think about, in particular over the last decade, is just more and more people groups being more and more affected and more increases. And I just think it speaks to just the widespread availability of a more potent product and some other issues that work as well. And I know you had mentioned the tragic death of a toddler this recently. It's in the news too. And I think just another example of just some of this, how extensive this is here. So all the more important reason for us to get together and see how we can be helpful.
So it's interesting too that I don't know if anybody from OTDA is on the call, but the population of people who are homeless, who were in shelters, this is definitely what we've seen too, is a huge increase in overdose deaths in that population. And so we have some initiatives that are new and expanding to provide services in homeless shelters. And so we're working with OTDA on that, of course, I think sometimes young people are not sort of like fall off the radar. And so I'm wondering, like, as we're doing that, thinking about a parallel specifically for young people, right, who are homeless, because we're doing it in the sort of general homeless population, where obviously we're going to see only a certain age group. But that is an initiative, and I think it seems like it wouldn't be that difficult to kind of think about, oh, well, we can expand that in more of the shelters or programs, whatever, for youth, not just for the adults. And so we are planning on expanding that program further, but I think we certainly should have conversations a little bit more with you and your agency about how we can include the youth as we're continuing to expand those efforts.
Thank you.
Hi, this is Valerie Figueroa. I do represent OTDA. I mean, my colleague Cheryl Contento could probably provide more insight in terms of, data in terms of what we're seeing with homeless shelters. But I do know we had a commissioners convene a few months back, and a lot of the commissioners were concerned about, the number of overdose cases that they were seeing in shelter. And so I'm not aware of the work that's being done in collaboration, with OASAS, but I do, obviously it's a hot topic for homeless families. And so, I'm looking forward to learning more about, what my colleague is doing, because I oversee the temporary assistance program where we do have like a substance abuse assessment portion for, temporary assistance recipients, but in terms of the work around prevention, that's not my direct, wheelhouse. But yes, I'm looking forward to the work that you all are doing with my agency.
Other questions or comments? Friday afternoon.
Yeah, I'm going to just grab a question of Charlie real quick. And, Charlie, I really appreciated all the information you shared. I know you had a lot to talk about with our folks with aging. And I guess I'm just thinking, like, it was a number of different interventions you were describing. And I wonder if any one of those stuck out to you as being more successful than others. And, you listed a lot of different things that you are doing, a really broad spectrum. I saw some primary and tertiary prevention strategies you were involved with. But is there anything that jumps out to you like, boy, this is really where we've been successful? I just wonder if that'd be helpful to talk about.
I think thank you. And I think the SBIRT, the screening one has been most effective given how our aging services network operates. So when somebody calls into their local office for aging or our New York Connects hotline, we have a 15-minute suite of assessments that gets run through to identify services and supports within our suite of offerings that may be appropriate, and entering the questions related to the SBIRT was seamless and did not require much additional lifting in terms of training or engaging our case managers who are already used to conducting these assessments in the home. We also have them certified as aging in place specialists, so they can they have more of an assessment kind of background to them. So I thought it has been successful and easily incorporated into our routine line of work, and an easy way for us to help expand the services and support opportunities that we can partner and collaborate with to our older adult clients.
Yeah, it's interesting. You talked about SBIRT as something that was successful. I'm glad you picked up on that one. What I don't know that SBIRT is commonly known to everybody in the group, by the way. So forgive me if I just explain that it's screening, brief intervention, and referral to treatment. And really it's a way of rapidly understanding where someone's at, and if needed, you find a way to refer them to treatment. So I think that's been around for a while. I don't know if you get reimbursed for that. I've seen some models in some states where people get paid to do that type of evaluations, the grant funding. I don't know if there's any compensation your team gets for that at all, or is that something, or no?
I don't know. OASAS might know more. I believe we do not get compensated for it, would be my initial reaction, because I don't think we have much in the way of reimbursable federal services and support.
Yeah, I've seen providers sometimes get paid for doing that when they're dealing that with patients as a sort of an evaluation, because it is something that takes a little bit of time, but not much. That's interesting. Well, thank you for sharing that. That was great.
It is a reimbursable service in
sorry.
Medicaid, but no. But we also have a grant. We have a federal grant as well. So that's really what's paying for these services, in our work with in this collaboration. But I think, as many people have said, I think a lot of the concern is it's a federal grant that's time limited, right? And there's an end to it as well. And so I think for us to think about, it's really great to hear, Charlie, what you're saying about its impact and its sort of success, and then thinking, of course, how can we continue to support that when the grant ends, right? And what we've seen is that even though it is a billable service, it like a lot of organizations don't know how to bill Medicaid. Like that's not what they do, right?
And most of the time.
Yeah, and even organizations that do, we certainly have heard that it's the reimbursement's not enough, that it's like challenging for the reimbursement, all of those things. So I do think that this is an area that is definitely on our radar, and it's with Office of Aging with older people, but it's really an intervention that can be used broadly, among any age groups in a lot of different settings. But I think the challenge is how to support that when it's not in a sort of a medical setting, but more in a community setting, how to be able to support that. So that's definitely on our radar. And, I think this, again, some of this, constantly goes back to money and budgets to support this kind of work.
Yeah, but that's a good example, Dr. Cunningham. It's like, Medicaid is in our department, but, I think you hit on a really important point, which is that, our other state agencies set up to bill for this. And, if there's a process to be taught, that might be where we can partner a little bit and try to cross some barriers. I can tell you, like, if you're even a physician trying to figure out how to bill Medicaid, most people, that's a process. Some people hire a consultant just to get it organized and have to work on it. So that's something that might be an interesting little recommendation for us to at least consider, is just how do we help each other learn how to bill Medicaid when it's appropriate? What are the criteria you need? So it's good. It's a good point.
Other questions or comments?
I think Pedro had his hand up. Pedro, I'm curious what you were going to share.
Yes, I hope I don't monopolize, but as well as there is no other questions. Last week, we talked to Carter Brown, and his presentation I thought was very interesting in pointing out that about around 80% of the law enforcement and Narcan engagement to prevent overdose were successful. So, and Joseph has talked about the OD map. So I would like to extend that question to Joseph, is that, do you have within the New York State an understanding of which law enforcement interventions are more likely to be successful in preventing an overdose? So in short, to turn a possibly fatal overdose to non-overdose? Because again, I think Dr. Captain Brown talked about over 1,000 interventions. So if we were to understand better what makes a law enforcement successful intervention rather one that is not, I think that would be a fascinating place to just improve that impressive intervention or right on at the moment of overdose. Thank you.
Yeah, I mean, from the literature that I've seen, it does seem to be that like 70 to 80% is a good kind of success rate for law enforcement naloxone interventions at reversing overdoses. I think it's largely because of the response timing from law enforcement, that they usually are staffed and are able to respond quicker than their similar emergency service counterparts, right? And so I think that's one of the powerful things of this program over the last decade, has been providing this life-saving equipment to people who are going to be there right away. I'd have to go look at more of the data on ODMAP to look at, how we break it down, success and not success. I do know, the special narcotics prosecutor in New York City is using a lot of health data from New York City to kind of focus their enforcement efforts, but also to enforce their or to help inform prevention efforts. So they're looking down to the block level and also to the location of the response. And so just in two quick examples, they showed kind of similar blocks where they've had an increase in overdose activity over the last 5 years, and also the type of location where the first responders are called to. So in one area, it was very much related to kind of an open air narcotics market where people were calling in overdoses that were publicly visible, right? So somebody was using in a public park or in a public business, and then someone calls and they saw a lot more successful overdose reversals. Versus a very similar kind of area of increase, but there weren't public overdoses that were being called in. It was happening in private residences. And so the success rate of overdose reversal was lower because of the fact that the response time was slower, getting naloxone took longer, and their medical services were delayed. And so I think it is about that kind of going within each community, looking to what is happening, and then tailoring the approaches, based on what you're seeing. But I do think universally it has obviously been very, very helpful to have, the thousands of officers trained and also equipped through DOH's and DCJS's efforts. So that's a long way of saying I have to get more granular with the data, but I do know that the data does break it down to that level, and that a lot of the public safety leaders and practitioners are using it to craft their strategies. So I hope that helps.
Yeah, and this is James Brown, State Police here. Just to piggyback off of Joe. Joe's absolutely right. It's all about response time. That's the key to successful successes when it comes to these naloxone uses. So obviously, the sooner whether it's the person that's overdosing or whoever that person is with, the sooner that person calls 911 or the local police department or EMS, that means the sooner first responders are dispatched, and obviously the sooner we actually get to the scene. So it's about response time, and the sooner we get to administer Narcan, the success rates definitely help out. Problem, however, is we live in New York State, and upstate New York is very rural, so our response time in New York City is sometimes seconds, and our response time in Raybrook, New York, upstate New York, could be 10, 15 minutes for any first responder. So those are some other challenges we have, but yeah, response time is definitely the key.
Thank you.
I don't want Dr. Branch to feel like we weren't paying attention to you, because I gave a nice talk as well. And I think for someone who has only been in their job 4 months, you certainly have a command of what's going on with veterans. But I'm just curious, Dr. Branch, do you think there's a gap in veteran services that we should be thinking about? And, as a veteran myself, I just know that, one of the things I just noticed about being a veteran is that everyone's service is their service and it's unique to them. And it's interesting how different everyone's service is. And I saw this a little bit with a civilian in the Department of Defense as well. It was interesting, some of the problems we were seeing among active duty service personnel, particularly those who are coming back from previous wartime engagements. But is there a gap that exists in the state that you think we should be thinking about collectively to work on our veteran services together, things we could be doing?
So my answer is yes. And to harken back to a point that you made with regard to systems versus marketplaces, even though the VA does have a health care system, the military does have a healthcare system, and the challenge, however, though, is systems do sometimes exclude their own members, right? And they do so based on knee-jerk reactions owing to what I would suggest is ignored context, right? And so for veterans, that ends them up sometimes with bad paper discharges, which puts them outside of a system to which they should be a fully accepted and participating member. And so what that means briefly is if a person gets a bad paper discharge, in some instances, they can no longer receive services from the VA healthcare system, right? And just speaking from a social perspective, we die in isolation, but we thrive in community. And so when you put people outside of community, it never bodes well and it doesn't end well. And just in terms of the gaps, I would suggest that veterans are an interesting population. So the military trains us to be a team, yet to be very strong as individuals. And to that end, a veteran sometimes, or a person who served sometimes, I'll say, won't ask for help because of that training that they have received all throughout their service to, be strong, be this, be that. A team of one, so to speak, in some instances. And so they are not inclined to seek out. They will try to innovate. And, the adage, necessity is the mother of all inventions. I think, though, in some instances, the cure that they try for the problem ends up being worse than the problem or exacerbating the problem. So, certainly forming partnerships, just going out and finding, asking questions in a different way. Because one of the things we find is that when we ask a person, are they a veteran? A lot of times a person may not understand that if they have served 4 years or however many years, they are a veteran because they equate being a veteran with someone who has been in the theater, in the theater of combat. And so asking if you are a veteran and then asking a clarifying question such as where did you serve, that might jog a person to reframe how they see themselves and give them permission, if you will, to, claim veteran status. So those are just some things that I think could be helpful.
Yeah, and thank you for saying that. I appreciate that. And I think, you gave a little bit of wisdom there, which I really think was great too. One of the things I was just thinking about when I worked for the Department of Defense as a civilian was how, and this is back in 2008, 2012, there was a view of medication-assisted treatment in the military. And, really was one of those things where I remember very distinctly trying to get it authorized for someone who was not an active duty service member, but a dependent, and how mountains of paperwork were done and how it was considered to really be taboo. I think that's changed a lot in the military in particular. But I think one of the things, I don't think you can serve active duty on medication-assisted treatment. I think, but there's some of these artificial barriers, which I think lead to perceptions when people leave the service, which make them less likely to do this. And I think one of those perceptions is, I look at opiate use disorder as a disease. It's diagnosed. There's criteria for it. It's like other chronic diseases. You might see relapses. There's treatment available. Want to help people. But I think sometimes active duty service members, when they leave the service, don't look at that opportunity as something where I should seek treatment, because I think there is a perception that it's a sign of weakness. Which, when you're creating a soldier, that might have merit. On the other hand, when you're creating a human being, I don't know that it does. So it does. It's a different population, to be sure.
And one other thing, I think that could be helpful. So we know that the VA does keep tons of stats. I don't think New York State does. And so if there doesn't seem to be a lot of info sharing between federal and state, at least that is my perception. It could be wrong. But if New York State were able to some way look at other sources of information and compile state-focused or state-centric data on veterans around the myriad of issues they have. So this way we wouldn't have to rely so much on the feds for information or other organizations for information. And just, case in point, I am DVS was fortunate enough to have an abstract submitted for an End the Epidemic conference coming up in, November. And so I'm the one who is tagged with presenting, and in trying to find state-specific stats on veterans. I was not able to. I found one report, but it didn't have any data with regard to AIDS, HIV that I could use. So I think helping to compile a state focused database with these numbers could be good, so we know what's going on in our own state around issues.
I think that's a good point, Dr. Branch. And I know that we definitely, when we look at who's in our treatment system and who's in our system, we do collect information about veteran status. As you said, it's self-reported, so I think it depends on how people see themselves. But we include that in our data, but the numbers are actually quite small. So it's sometimes hard to know how accurate it is, just because of it's being very, very small. And it may mean that a lot of veterans are really receiving services more in the VA system as compared to in our OASAS certified system. But I do think it's a really important point about the data at the state level. So it seems like we have a lot of time for, again, discussion, but we don't have to stay on. I mean, this meeting is set through 1 o'clock. But I feel like if there's, you know, no sort of burning questions or comments, we could end the meeting early. I'm not sure what your thoughts are, Dr. McDonald. Who seems to be, I'm not sure if you know you're muted or if you're, so just to make sure everybody knows, we have our in-person meeting next week. It's in a few days from now on Wednesday in Staten Island at 3:30. I'm sure everybody has gotten invites. I know there's been some questions about the ability to join the meeting remotely, and that is a possibility. So I know Tracy, you provided a link.
We can provide a link. Anyone that needs to participate remotely, we can provide you a link. Or actually, I can even just send it out to the full group, and then if you need to participate remotely, that's fine.
Okay. And we do have time for public comment at this meeting. So again, if you know, making sure that your stakeholders are aware of this so that people can come and give public comment as interested. So I think if there are no other comments or questions, we can adjourn. Thank you very much for the discussion and the presentations, and we look forward to seeing many of you in person, hopefully next week. Have a good weekend, everybody.